My name's Trina Moyes. I am the Manager of Return to Work Performance at the State Insurance Regulatory Authority, CIRA. In case you're wondering, I am what a Return to Work Performance Manager might do at CIRA. I lead a highly skilled team of allied health professionals, and we focus on the measurement of recovery through work and activity, performance, and we also look to develop strategies to improve outcomes for people with injury. So look, I'm delighted to have this opportunity to be here today and welcome you to this morning's session and today's speakers here in the Grand Ballroom. I hope the session will be both insightful and impactful as we aim to evolve our journey in the personal injury schemes. You may be aware of a recent study by Monash. It was published in March of this year, and it looked at data analysed from about 30,000 people with injury in the schemes over a 10-year period. And of those, they found about 20% of those, so 1 in 5 of those people who had time off work were prescribed opioids in the first 3 months of their claim. So this topic is one that I think we'll all find very interesting. CIRA also have published a better practice guideline on the use of opioids on our website for anyone who's interested afterwards. I want to take this opportunity to then introduce today's speakers. Mr. Luke McGrath, who's an independent med management consultant and of All Meds AI, and also Luke Ogilvie from Suncorp GIO, experienced IMA, and the two Lukes are going to talk today on the pain of deprescribing opioids in workers' comp, shaping the future of patient care and scheme sustainability. Just before I hand over, I'll just mention that we are allowing time at the end for question and answers. For anyone who wasn't here yesterday, like myself, there's an app available. You go there, you look at the session, and you can send live questions through that will allow some time at the end. So I'm going to hand over to the two Lukes. Thank you.
Thank you very much. So, as introduced earlier, my name is Luke Ogilvie. I'm a wellbeing specialist for Suncorp in the small to medium space employers. I've got an extensive history in workers' comp, so I've got over 20 years. I've also worked for large corporates in the return to work space, as well as work health and safety. It's a pleasure to present today.
I'm also Luke McGrath from Independent Med Management and allmeds.ai. So we identify now and manage medication use within the workers' comp and CTP space. Quite extensive experience as well, over 10 years working in this industry, managing medications, and with a focus of optimisation and deprescribing, really. And throughout the presentation, you'll probably understand why we're encouraging deprescribing of medications. We see it very differently in workers' comp than what we do in general community patients. So I know there's different professionals in the room, rehab and insurers. So I want you to think about medications from the aspect from your profession and what that really means to you and your patients or injured person, especially when it comes to the insurance space, whether that means the claims elongated, whether it's increased costs, whether there's secondary liability issues and conditions that you're then liable for when used long term. And then from a rehab profession as well, what that means when a person's over or under medicated for their ability to perform their tasks for rehabilitation and return to work. Sorry, we probably should have changed slides before.
Yeah. So, starting with the why. So, why should we bother reducing opioids?
Yeah, well, obviously it's a high-risk medication. Comes with significant risks associated with it, and we do speak a lot about the addiction dependence issues when it comes to opioid medications and other addictive meds. But in the context of today's presentation, talking specifically around opioids. Yes, it's the addiction and dependence that keeps people on these medications, but it's the long-term effects that have the detrimental effects on people's ability to recover. So that's things like increased risk of overdose, and rehospitalisation, falls, all those sort of physical things. But when a medication is used long-term like this, we need to start talking about things like adrenal insufficiency, hormone issues, sleep conditions that's going to become an issue after that, which therefore leads into the secondary conditions that you guys then have to manage and identify and investigate whether it's a liability concern, whether it's going to be compensable or not. So what are some of the downstream costs that you'd see associated with long-term use of opioids in this instance, but long-term medications that have an impact on recovery?
So as you rightly pointed out, that we need to have the investigation costs. We may need to seek independent medical advice, so an IME. We may need to request clinical notes. We may need to do subsequent investigations. So for instance, if the medications cause a gastric tract issue, we may need to pay for a colonoscopy or an endoscopy, a referral to a gastrologist, and then all the associated costs of that. So then if we accept the secondary injury, we then may need to consider the wages component attached to that and all the medical costs. So it's not unusual for us to spend tens of thousands of dollars potentially trying to manage a secondary injury.
And then, like you said, plus the costs associated with the treatment of that condition for possibly lifelong. One of the considerable facts here was that, as we said before, that medications when used initially, and opioids a lot of the times are prescribed in that initial acute injury phase without sort of this plan of deprescribing or stopping the medications, which is the problem. We see that 3 in 4 people that are using high-risk medications and opioids at 12 weeks are still using the same medications at 52 weeks. So when we start to talk about interventions like IMM and other sort of services that you can do, we need to start talking about this in that early intervention space, trying to prevent these from becoming an issue, rather than trying to catch the ball at the other end.
So it comes down to comes down to the how. So we looked at it. It started off for us as a cost analysis point. So we started looking at the use of the medication lists in a tail space, trying to look at controlling costs. So we identified a group of claims on a monthly basis where highlighting the amount of cost spent. So then by using the SERA codes, the PS 100 for instance, we're able to then lead to have a look at the claims costs against those codes. So we were then able to, by highlighting the high spend, we were then able to look at referring to companies like IMM around helping us to manage those costs.
I think cost was obviously the key identifier for a lot of those claims, right? But as you dug deeper, obviously through the PHS coding, but also through the one-on-one consults with a pharmacist going through the medication or the claims that you'd sort of identified, it was able to then sort of identify the spend, identify the complex claims that actually needed further intervention. So although cost was like the key identifier, it was actually the identifier of the complex or high cost pharmacy spend.
Yeah, exactly. So while the costs identified the risk for the claim, what it actually, in hindsight, identified was the greater risk for the actual management of that claim. So the costs identified that we were spending a large amount of money on opioids or any medication, but it actually, the underlying cause was not identified by cost. It was actually identified by the pharmacist identifying that this person was potentially on multiple medications with not a lot of ability for the claim to control.
So I want to talk a little bit about how patients end up with such a complex medication list. And it's through a lot of issues within the system, and especially it gets more complex in workers' comp where sometimes you have multiple prescribers, so multiple treating doctors, whether that's treating claim-related and unrelated conditions, whether it's multiple doctors treating the same condition with divergent treatment plans. So basically treating the person with different medications and basically not knowing about each other. So you end up with this prescribing cascade, medications being used to treat side effects associated with the preceding medication. And it's not uncommon for us to see, 20, 30, 40 medications for some person prescribed. And I think that's outrageous.
So are you identifying that the gap is the fragmented care as in the number of prescribers, or is it the fragmented care as in because there's a limit to oversight, or what's your
I think it's a bit of both.
There?
Definitely both. And I think there's a communication lacking factor as well, where prescribers don't generally communicate with each other, introducing the fact that we now have made cannabis for self-referrals and all those types of concerns. But I guess the overall key point here is that doctors don't generally prescribe complex medication lists off the bat. They get there over time. So the sooner we can get involved in mitigating that prescribing cascade, then the better outcomes you're going to have for the patients. Other factors that we see, obviously lack of specialist oversight, and in this case study that we're going to go through shortly, this was actually one of those ones that didn't have a specialist overseeing the medications that the GP was prescribing, and we see this time and time and time again. Sometimes it's good, sometimes it's bad. We know that specialists can often point people down the surgical and interventional pathways rather than just being the simple medication improvement strategy first, before consideration for spinal cord stimulators and those kind of weird and wonderful things. And they missed early intervention opportunities that we get to see in workers' comp, because it's hard for an insurer to justify spending money in the front end space, preemptive and preventative treatments, because it's hard to prove prevention, right?
But are you saying that we should consider more early intervention, so in a claim space, more early intervention to identify the use of medications?
Absolutely, yeah. As soon as you can justify spending that sort of money on a claim, and as we've seen, over the last couple of days, yesterday, that intervention early can prevent that long-term costs. We've just got to start putting that into practice. So I want to go through a case study. This will be pretty eye-opening for a lot of people. And this is not uncommon. It's also quite complex, and just because this person's complex doesn't mean that somebody taking 2 or 3 medications isn't at a significant risk of themselves. But this was a particular one that got referred to us from GIO. And as you can see here, quite a complex list of medications. And PHS coding obviously helps with identifying these types of things. But this person's on 3 different opioids, a sedating antidepressant. They're also taking Lyrica, which is another medication that I think gets swept under the rug a little bit just because it's a Schedule 4, which would be a PHS 400 med, which is not really high on people's radar. Considerable concerns. Stilnox, and then some unrelated conditions that he was treating with multiple medications as well. So as a pharmacist, we look at this and think, okay, how can we prioritize what to do in this particular situation? So this guy was really clutching at straws. He was no specialist oversight, as I said. GPs kind of just prescribed these medications and trying to manage this as best they can with the knowledge that they've got. And so we sort of came up with a priority here. So obviously the primary outcome that you guys referred for was opioid management, because it was identified.
That's correct.
But this guy, when we reviewed it, was consuming significant amounts of alcohol, trying to self-medicate for his sleep while still using Stilnox, a Z drug, which is a massive concern. So instead of focusing on the deprescribing of opioids in this particular instance, we actually focused on improvements in sleep, improvements in alcohol use, and therefore reductions in the Stilnox. So that was the primary focus, which we did successfully in the first sort of 3 or 4 months. And whilst we did that, we did an opioid consolidation plan. So
Why did you choose that approach?
I think it needed to be addressed first because we thought as the pharmacist that was the major concern, especially when there's that contraindication, there's risk of significant adverse effects. Like Stilnox by itself is concerning, and it should only be used for like 2 to 4 weeks maximum. This person's been on it for 3 years. Crazy. So because of the alcohol use in the Stilnox, we thought that was better. He was also had a bit of a breakdown in his relationship as well because of the sleep and because of the significant impacts of the medications. So that was the focus. We thought that if we could get his sleep and mental health sort of stable, then we'd have more success in reducing his opioids over a period of time. So that's exactly what we did. Over 12 months, which you might think is a long time, but for a complex claim like this, it's actually, a significant benefit. And if you guys hadn't have referred this to us, this medication profile most likely would have stayed the same forever, unchecked. So good pickup from you guys.
Thank you.
But I just want to talk a little bit about the process of how we sort of manage this and why we prioritise what we did. But in doing what we do, we now have access to real-time prescription monitoring. So we can see exactly, as pharmacists, we can see exactly who's prescribing and what they're prescribing for high-risk medications. And that's state-specific, which is another concern in itself. But it's nice to be able to see that, see which pharmacies they're being dispensed from. And we can actually contact those pharmacies and get a 12-month dispense history. So that gives us a really comprehensive oversight, more than what an insurer would have, and more than what the GP has. So often we're going to the GPs with more information that they've got about their own patient, so they can make more informed treatment decisions and start to rationalise medications. So over the 12 months, we managed to get this person off all medications other than Mobic as the claim-related med. And not only that, is we improved asthma and we improved his hypertension. So in doing a medication review, even though it's not so much the insurer's responsibility, it's certainly not the pharmacist's responsibility as an IMM pharmacist, but you'd be mad to not do a job to completion and sort of improve this as much as you can overall, even though it was unrelated. So this person had amazing outcomes. Back mowing his lawn, which he was stoked with. Back having a really good relationship with his wife, that sort of improved. And he didn't return to work because it was quite a complex injury, but to have somebody that's feeling a lot better, stopped all alcohol consumption, obviously the Z drug was gone as well, huge win. So I think this speaks volumes to how bad things can go when medications are managed poorly, but how good it can get if they're managed appropriately. So when used well, medications can really significantly impact positively on somebody's ability to return to work.
Yeah, it's a really good positive return to life rather than return to work at that point in time. So at that point in time, return to life was a short to medium goal. So with that, what do you think the solution is for us moving forward? Is it more independent oversight? Is it more tailored management plans? Or follow-up? What do you think is the best solution for us, or is it a combination of all of it?
I think it's a combination of all, and the reason being is independent oversight. Now that we've got so much information that the dispensing pharmacy doesn't get, which I understand, but now with doctors being short on time, pharmacists being short on time, people aren't getting the information that they need about the medications to make informed decisions for themselves about whether they want to continue using them or not. And if there are better alternative treatments out there as well. So independent oversight as early as possible is my recommendation to prevent these types of things from happening. And as an insurer, you just have to justify where you want to do that. I think it's a sweet spot at like the 26-week point, but definitely before that 52-week mark. And the reason being is when we get the 12-month dispense history, our reports are basically medical legal reports. So it's informative for the GP, it's also informative for the insurer. And so if we can do this prior to that 12-month, 52-week point, we can also identify what treatments were preceding the injury, therefore most likely identifying things that were pre-existing. So that's part of the reason why we think independent oversight's good. Tailored management plans, as you can see in that case study, you couldn't just do a one-size-fits-all approach to saying, hey, reduce your medications by 5% to 10%, and go from there. It just wouldn't have worked. And you would have missed out on all the opportunities to improve the other medications and then obviously improve their life. So, tailored management plans, clear documentation and follow-up. We need to follow up with the doctors to make sure they're implementing the recommendations that we've made.
So how would a pharmacist decide between an opioid rotation or rationalisation?
Again, it comes down to that tailored management plan, and it's a clinical decision between the pharmacist and the prescribing doctor, because at the end of the day, it's the doctor that makes the decisions on what they're comfortable with and what they think is appropriate for the patient. But obviously, the goal is to deprescribe the opioids, and how we do that can be through various different things, and that's opioid rotation to a different molecule at a 50% reduced rate. It can be consolidation, so rationalisation, reduction, cessation. And then obviously the gradual reduction is there as well of the same medications that they're on. However, that's generally a slower approach, but sometimes most effective. But these are the suggestions that we can take to the doctor, and if one doesn't work, we can recommend some alternatives at that follow-up time frame. So I just want to go through some outcomes really quickly as to what we did for these claims. And this was on around 300 services 300 referrals. We did 700 odd services for 300, so that speaks volumes to the follow-ups that we did. But a significant reduction in opioid reduction for this particular cohort. But all of these patients were also using other medications. So 58% reduction cessation of opioids, 33% cessation of...
Which is pretty impressive.
Especially in the cohort of claims where they're 5 to 10 years old. Cessation of gabapentinoids, benzos, sleep drugs, reduction in psychiatric meds. And the biggest thing that I take from this is that these people are off these medications, but they're feeling better. So it's not just stopping medications in the hope that they find alternative treatments. It's that they're getting off these medications and feeling a lot better on the other end. I know we're running short on time, so I'm just going to fly through this really quickly.
So where to from here? Is this where we need to head? Is this where you think the industry needs to head?
100%. So embed this as a structure in your claims management process and use the data that you've got available to you. Sarah's got the PHS coding in New South Wales, but each state's got their own sort of processes on how to identify high-risk medications. At least they should. And then utilising the tools that are available. So now we've launched allmeds.ai. So this is taking the responsibility off the case manager or the IMAs to identify these types of risks. It's a pretty simple process in uploading a pharmacy receipt, dispense history, an IME, certificate of capacity, even with a medication list on it. This will actually identify any kind of medication-related risks for that. So for this in the process, I would suggest identifying the risks, taking that to the doctor, and having the doctor try and mitigate those risks. And if they can't come up with a strategy for doing that, cool, you can identify those claims and then they can be the ones that get referred to.
So you're suggesting that we could use that report to refer to the GP or the NTD or the specialist to say, this is the profile, we would like you to review that and make changes to that profile to better reflect what the worker needs or their patient needs?
Yeah, leveraging AI to identify the risks, therefore being able to triage the claims appropriately. So this is extremely inexpensive and immediate. So case managers can do this when they're performing any kind of tasks throughout the day and identify the claims that need oversight. If you want any more information on that, come see me at the end. But yeah, thank you. I think there is a little bit of time for questions. But yeah, appreciate your time.
Thank you.
Well, I'm glad you left a little bit of time because there's a million questions here. Okay, so I'm trying to work out which one's most important. But first of all, is IMM a national service? And how do people make referrals?
Yeah, we try to make referrals as simple as possible. So we do have a secure online referral portal, i.e. referral form and upload documents there as well. It is a national, it is available nationally. Work cover WA. We haven't done any work in WA yet, but we're certainly open to it.
And how do doctors and specialists actually react to your involvement coming in and perhaps is there a lot of collaboration going on?
There is now. Originally, when this service sort of started in the industry, you get this hierarchy between doctors and pharmacists, and doctors are somewhat like, how dare you as a pharmacist tell me how to manage my patient? But I mean, I spoke to the slide before about the outcomes. 81% of doctors actually implement at least one of the recommendations that our pharmacists make at the time of the primary assessment. And I think that's their, proof in the pudding that they are making appropriate recommendations, that the doctors are willing to implement those changes. So yeah, originally it was challenging, but we are now more level pegging field with doctors because we are such a valuable clinical resource to the doctors, and then obviously valuable resource to insurers for the medico-legal type side of things as well.
And that kind of probably answers one of the questions here, which is just about how might you constructively get doctor on board with actually arranging that independent consultation.
Yeah, the challenge is in the sale. So it's how are you convincing that doctor that that strategy that you've put forward is appropriate for that person. But like I said, the doctor's clutching at straws at this stage as well. They're looking for other solutions. So just for having that outside perspective, they're very receptive to it now. And even if they are perceived to be perceptive to it, we can follow up in 3 months, 6 months' time and see whether they've actually implemented the changes that we've recommended.
Yeah, great. I guess there's a question here about general medical practitioner education and how much does that education of prescriptions play a part? Do you think there's more education that's actually required? Are there any other implications of supplying the pharmacy?
Of supplying the pharmacy, did you say?
Sorry, go to the first part of that question. Are there thoughts around a lack of education, a lack of knowledge by GPs, or is there another reason there's the over-prescription that you're talking about?
I think it's a accumulation of lack of knowledge but lack of time and structure to the appointment times. So doctors are sometimes, if there is a specialist involved, a specialist might say to the doctor, stop the opioids. That's as far as it goes. We need to do a deeper dive into that, because if the doctor wanted to stop the opioids, they would have stopped it previously, right? So we need to actually do a deep dive into that, create a plan that's structured and tailored to that person for the doctor to then implement. It's not as simple as just saying stop the opioids. They're not appropriate. You have to give them some solutions.
And that kind of leads to another question here about there were 81% who adopted the recommendations. Why not the other 19%? Yeah.
Various reasons. Who knows? A lot of the times there's surgeries pending, so they're not going to make any changes until following surgery, or sometimes they just disagree with what the pharmacist is saying, and you get these doctors that are, stuck in their way and not open to alternative suggestions. They're the ones that you might want to escalate with Sarah. Or try and convince them in a different way, offering them resources or clinical studies and things where you can say, hey, what you are doing is not great for that person. You've obviously not received it well from me as a pharmacist or from our pharmacist, but here's some resources that you might want to consider. And a lot of them do. Once they've received the clinical, a report, they read it, and they might not have agreed to it at the time in the heat of the moment, but they read it and they think, okay, that's a justified approach. Cool, I'm going to start doing something like that.
Yeah.
But we just don't get to hear that outcome.
There's a question here about reducing opioids by how much, the frequency of dispensing, and what's the dose?
Subjective. It's a challenge. I mean, that's that one-size-fits-all approach, right? It's 5 to 10% per 2 weeks or a month, depending on tolerability. But that's such a blanket rule, and depends on what strategy you've chosen, whether it's an opioid rationalisation, reduction, rotation, all those sorts of things come into play there as well. So it's not a one-size-fits-all, and it is definitely a discussion that needs to be had by the pharmacist and the doctor, rather than just an insurer saying, do this by 10% every 2 weeks and see at the other end.
Yeah. What are your thoughts about whether claims managers should have the authority to request the PBS records when they have concerns over prescription and sometimes about doctor shopping? A question for Luke. Yeah.
Well, we'd love to be able to have that access to the information in real time so that we could help make decisions. Whether we have, there's obviously the privacy constraints potentially for that, but it'd be, the information is power. So if we have that information, so we then were able to make decisions in real time, it'd be great to be able to access that information. But obviously we need to be mindful of the privacy implications there.
I'll just add to that as well that Allmed's AI system does have a pricing module to it as well, so it does determine whether the medication's available on the PBS or not, and whether you're getting charged reasonable prices for it. So that's a pretty simple AI immediate response that you can get, but it's also something that we do in our primary assessments, the manual medication reviews, where we're discussing pricing with pharmacies and making sure that that's appropriate as well. So the information is available to the insurers through a third party, unfortunately, because you still need to be a pharmacist to access that type of info.
There's quite a few more questions, but I think we've probably come to the end of our time. A couple of the points that I just wanted to call out, because for me they were huge. You mentioned that, because I said at the beginning that the Monash study looked at maybe 1 in 5 injured workers were prescribed opioids within the first 3 months, and they're of the people who have had time off work. But you mentioned that after 52 weeks, 3 in 4 of them were still on opioids.
Yeah, so the profile hadn't changed at the 12-week mark.
Yeah.
So even
Of the people that did get prescribed opioids, the people that did, 3 in 4 of them were still on the same opioids after 52 weeks.
Yeah.
Early intervention is definitely the answer. How we do that, it's up to you guys.
Yeah. Okay, I think we'll call it time. But thank you so much to Luke and Luke for your expertise.
Thank you very much.
Today, much appreciated. Yeah.
Thank you, guys.